This is Chapter 9, Eating Disorders. So today, thinness is often equated with health and beauty, and it's become a national obsession within our culture. There has subsequently been a rise in eating disorders that has been fueled by a morbid fear of weight gain. There are two main diagnoses that we'll look at: anorexia nervosa and bulimia nervosa. There's also a third that's on the rise, and that's binge eating disorder, so we'll explore that as well. So the main symptoms of anorexia nervosa: a refusal to maintain more than 85% of normal body weight, an intense fear of becoming overweight, and a distorted view of weight and shape. A consequence of this is amenorrhea, which is cessation of the menstrual cycle, so it's a common symptom. The clinical criteria for anorexia nervosa is that the individual purposely takes in too little nourishment, resulting in body weight that is very low and below that of other people of similar age and gender. The individual is very fearful of gaining weight or repeatedly seeks to prevent weight gain despite low body weight. And the individual has a distorted body perception, places inappropriate emphasis on weight or shape in judgments of herself or himself, or fails to appreciate the serious implications of her or his low weight. So there are two main subtypes for anorexia nervosa. The first is restricting type, and in this case, they typically restrict the intake of food. Approximately 50% of the people who are diagnosed with anorexia nervosa fall into this category. And then there's the binge eating purging type, and so this is indicated by vomiting, often using laxatives or other methods of removal, and then binging. So the prevalence for this is about 95% of the cases are female. The peak onset typically is between late adolescence through early 20s, and it affects 0.5 to 4% of Western females. It's increasing in North America, Europe, and Japan. And the key goal for people with anorexia nervosa is becoming thin. Their driving motivation, again, is fear. People with anorexia nervosa are preoccupied with food. They think in distorted ways, and they display certain psychological problems. The starvation habits of anorexia nervosa cause a range of medical problems: amenorrhea that I mentioned earlier, also low body temperature, low blood pressure, body swelling, reduced bone density, slow heart rate, metabolic and electrolyte imbalances, dry skin and brittle nails, poor circulation, and lanugo, which is a development of fine hair that's similar to the fine hair that covers newborns. For bulimia nervosa, which is sometimes referred to as binge purge syndrome, the characterizations follow. So engaging in repeated bouts of uncontrolled overeating during a limited period of time, and eating objectively more than most people would or could eat in a similar period. So the clinical criteria: repeated binge eating episodes, repeated performance of ill-advised compensatory behaviors, for example, forced vomiting to prevent weight gain, and the symptoms typically take place at least weekly for a period of 3 months. Inappropriate influence of weight and shape on appraisal of oneself is present here as well. So many teenagers and young adults are affected by bulimia nervosa. They go on occasional binges or experiment with vomiting or laxatives. Only some of these individuals will actually qualify for a diagnosis of bulimia nervosa. Others may just be, again, experimenting. Patients are generally of normal weight, and they engage in inappropriate, again, compensatory behaviors. The prevalence is 90 to 95% of cases are female. At the onset is between, again, late adolescence and early 20s. The weight often stays in the normal range. There are some exceptions to that, but this is different, again, an exception from anorexia nervosa, where typically it's visually clear because they are underweight. So look closer at binges. They're usually preceded by feelings of great tension, and so the actual experience of binging may be pleasurable for the person. They may include between 1 and 30 binge episodes per week, and they're often carried out in secret. They involve eating massive amounts of food very rapidly with little chewing. After a binge, they may compensate for and undo the caloric effect. Often the way that they do this is through vomiting. Compensatory behaviors may temporarily relieve the negative feelings that are attached with the binge eating, but over time a cycle develops in which there is purging, binging, purging, and so forth. So look at the similarities and the differences between anorexia nervosa and bulimia nervosa. For similarities, both begin after a period of dieting, often. Both are involving a fear of becoming obese. The drive to become thin motivates both. In both, there's a preoccupation with food, weight, and appearance. Feelings of anxiety, depression, obsessiveness, and perfectionism exist with both. There's also a heightened risk of suicide attempts for both. Substance abuse is common for both as well. Both entail a distorted body perception, and both entail disturbed attitudes towards eating. For differences, people with bulimia nervosa are more concerned about pleasing others, being attractive to others, and having intimate relationships. People with bulimia nervosa tend to be more sexually experienced and active, and people with bulimia nervosa are more likely to have histories of mood swings, low frustration tolerance, and poor coping. For binge eating disorder, like those with bulimia, the individuals believe that they are going to be able to control their life if they engage in the binging. So there's a kind of sub-element with all of these disorders actually, where if the person feels that they don't have control in their larger life, that they feel like they can regain control through these acts. As a result of their binges, about 2/3 of people with the disorder will become overweight or obese, but most overweight people do not binge. So just to clarify, not to assume that just because of seeing someone who is obese. So the clinical criteria for binge eating disorder: recurrent binge eating episodes. Binge eating episodes include at least 3 of these features: unusually fast eating, the absence of hunger, uncomfortable fullness, secret eating due to sense of shame, subsequent feelings of self-disgust, depression, or severe guilt. And then again, significant distress, as we see often with other disorders. Binge eating episodes typically take place at least weekly or over the course of 3 months to meet the criteria. And the absence of excessive compensatory behaviors. So the symptoms and characteristics again for binge eating disorder. The patterns are similar to those seen in bulimia. Those with binge eating disorder don't perform inappropriate compensatory behaviors, however, and they're not typically driven to thinness or efforts at extreme dieting. They often do become overweight or obese. The prevalence is between 2 and 7% of the population, and there aren't any large gender differences with this disorder. So there is a little bit of overlap for these 3 disorders, and you can see that here. Okay, so obesity, obviously, again, is something that will overlap with binge eating disorder commonly. And then normal weight for bulimia nervosa, that's going to be in the center with the yellow circle. Okay, so typically they will maintain normal weight despite the disordered behaviors. And then binge eating of the purging type and anorexia nervosa can also have a crossover there, as you can see with the green. And then the restricting type of anorexia nervosa disorder, again, which is where they are more severely underweight, you can see on the extreme end of the blue. We'll take a look now at what causes eating disorders. Most theorists and researchers use a multidimensional risk perspective to explain the eating disorders. The factors include psychological problems, biological factors, and sociocultural conditions. From the psychodynamic perspective, Brooke believed that there were ego deficiencies or a poor sense of independence and control. He also believed that there were perceptual disturbances, for example, body dysmorphic disorder, where the person literally sees a different image in the mirror than what actually exists in reality. And then again, strong traits of perfectionism. They also looked at effective versus ineffective parents. So accurately attending to child's biological and emotional needs describes effective parents, and failing to attend to children's needs, deciding that their children are hungry, cold, or tired without correctly interpreting their child's actual condition, is an element of ineffective parenting. There is inaccurate emotional cue perception that we find, so the research helps to kind of support these ideas. When we have inaccurate emotional cue perceptions, this means that we're confusing emotions with hunger, okay? And they find that people who have eating disorders do commonly have this. There's also alexithymic, this is the difficulty labeling emotions. So this is also a condition that we find often in people with eating disorders. And then excessive dependence on the views of others, especially again for those with bulimia nervosa. So the idea here is that because we've been able to see these common traits among people who have been diagnosed with eating disorders, there is some support for these ideas of ego deficiencies, perceptual disturbances, and parenting style. So this is in your text as well, just an overview of when people often seek junk food, okay? So there is an emotional connection between how we all eat, and what we're looking at with eating disorders is, an extreme and disturbed version of that, okay? But typically all of us, when we are bored, we tend to seek out junk food. We tend to eat more than we normally would if we weren't. If we are depressed, we tend to seek out junk food more. If we are anxious, we tend to seek out junk food more. There's also a little bit though with positive feelings. So if you are in love, sometimes they will make the joke about kind of happy love weight, right? And then if you are happy, then we start to see kind of a sharper difference here. So if you're happy, you're much less likely to seek out junk food. And if you're feeling very self-confident, you're also much less likely to seek out junk food. So from the cognitive perspective, there is a belief that there's a broad cognitive distortion at the center of the disordered eating. That includes improper labeling of internal sensations and needs, as we looked at with the previous perspective, and also little feelings of control over the person's life and a resultant excessive feeling of control over their body size, their shape, and their eating habits. So again, trying to compensate for a larger sense of lack of control by controlling things that do seem to be controllable within their realm. Mood disorders often set the stage for eating disorders. So a clinical diagnosis of major depressive disorder is more common for those with eating disorders than those without eating disorders. And there are higher rates of mood disorders among close relatives of those with eating disorders than those without eating disorders. There's also low serotonin activity compared to those without eating disorders. And eating disorders often are helped by use of antidepressant medications. So we do see that there's an overlap between, again, depression, mood disorders, and eating disorders. We look at some biological factors. Biological theorists suspect that certain genes may leave some people particularly susceptible to eating disorders. Other biological theorists posit that eating disorders may be related to dysfunction of the hypothalamus. The lateral hypothalamus produces hunger when it's activated, and the ventromedial hypothalamus reduces hunger when it's activated. And there's also a weight thermostat. You guys should remember this from introductory psychology that establishes a weight set point. And so the idea is that if this system is disordered or deficient in some way, that could contribute to an eating disorder. There's also consideration for societal pressures, and these are things you've likely heard discussed in the media several times throughout the last couple of decades. So Western standards have changed throughout history toward a thinner idea, and there's often prejudice against obese people. The socially accepted prejudice against overweight people may also add to the fear and the preoccupation about weight that's experienced for people with eating disorders. A recent survey of adolescent girls tied eating disorders and body dissatisfaction to social networking, internet activities, television browsing. And we also know that there is a factor of the family environment as well. Some really interesting information here. So families may play an important role in the development of eating disorders. Abnormal interactions and forms of communication within a family may also set the stage for an eating disorder. So an enmeshed family pattern is one in which the members are overly involved in each other's affairs and the details of each other's lives. And there does appear to be a correlation between individuals who are a part of an enmeshed family pattern and having an eating disorder. To look at multicultural factors, there are some racial and ethnic differences. A 1995 study reported that eating behaviors and attitudes of young African American women were more positive than those of young white American women. Recent research suggests that body image concerns, dysfunctional eating patterns, and eating disorders are on the rise across all ethnic groups, however. And this is likely the result of acculturation, meaning that those who are not in the majority culture are starting to adopt their patterns. We've said before that this largely impacts young girls and women, but there are experiences, of course, of eating disorders among males as well. Males account for only 5 to 10% of all cases of eating disorders. And of course, there is a double standard for attractiveness that could account for this difference. Also, there are different methods of weight loss that are favored between the genders. And there are links to requirements and pressures of a job or sport. So reverse anorexia nervosa and muscle dysmorphia are often diagnosed for men when they do experience eating disorders. We'll take a look now at how eating disorders are treated. The main goals of eating disorder treatments are to correct dangerous eating patterns and to address broader psychological and situational factors that have led to and are maintaining the eating problem. The immediate aims of anorexia nervosa treatment are to regain lost weight, and to recover from malnourishment, and to teach them to eat normally again. So the way that they restore proper weight and normal eating, in the past it's been hospitalization. Recently, however, there's been an uptake in daily hospital or outpatient treatment, nutritional rehabilitation programs, and behavioral and cognitive interventions. Therapists help clients recognize their need for independence and control, recognize and trust their internal feelings, change their attitudes about eating and weight, and correct disturbed cognitions and learn about body distortions using cognitive approaches. There's also an attempt to change the family interaction. So family therapy is important for anorexia nervosa treatment in particular. It addresses separation and boundaries and uses combined treatment approaches. The course and the outcome of the disorder vary from person to person, but even with combined treatment, recovery is often difficult. Positive treatment outcomes include weight gain that is often quickly restored, menstruation often returns with return to normal weight, and death rate, of course, declines. Negative treatment outcomes, as many as 25% of patients remain troubled for years. Even when it occurs, recovery is not always permanent, and there are often lingering emotional problems. For bulimia nervosa, treatment is frequently offered in eating disorder clinics, and the immediate goals of treatment are to eliminate binge purge patterns and underlying causes and to establish good eating habits. The programs emphasize education and therapy. From a cognitive behavioral perspective, the techniques include diaries and exposure and response prevention. Cognitive techniques include maladaptive attitude recognition and change, and recognition of binge urges and negative thoughts. Other forms of psychotherapy include interpersonal therapy and psychodynamic therapy. So if clients don't respond to cognitive behavioral therapy, these are approaches that may be sought. For interpersonal therapy, the treatment seeks to improve interpersonal functioning. And for psychodynamic theory, that is similar to what you've seen before. So it's the idea is accessing and increasing insight about underlying subconscious urges, desires. Combination therapies are also common, so family therapy in a group or an individual therapy as well. There's also, as I said earlier, the use of antidepressants sometimes. So during the past 15 years, all groups of antidepressant drugs have been used in bulimia nervosa treatment, and medications are best when used in combination with other forms of therapy. The aftermath of bulimia nervosa, if left untreated, it can last for years. If treated, significant short and long-term improvement can occur for many. Relapse can be a significant problem, and they're usually triggered by stress. They're more likely when the person had a longer history of symptoms, vomited frequently, had histories of substance use, and has lingering interpersonal problems. Binges play a key role in bulimia and binge eating disorder, and treatments are often similar. So cognitive behavior therapy, other forms of psychotherapy, and antidepressant medications. Additional interventions for overweight people with binge eating disorder exist as well. And specialized treatments are emerging as this disorder continues to increase. All right, so that is our eating disorder chapter. Remember that your learning curves are due by 11:59 p.m. Friday. Your test is due by 11:59 p.m. Sunday. And as soon as you've completed those things, go ahead and start with Chapter 10 with your reading and your learning curves. Remember that CTC is closed on Tuesday. We have a staff and faculty in service, so we won't be having classes on Tuesday. And I will see you all on Thursday. and that is when your midterm portfolio will be due. I will go over that in class with you today.